Yes, I choose this topic because this is one of the mostly tested in exam and mostly met in the practice that we have facing every day today. And during my presentation, I focus on more technical issue and more of concept and understanding rather than the theory part. So I would like to have some cases at the end. We have interaction with you guys, inshallah, and we will go through it together. So the outline of my presentation, I will talk the brief introduction about mitral regurgitation and the importance of mitral regurgitation. And then the presentation will be mainly focusing in the echocardiographic part and echocardiographic assessment of chronic mitral regurgitation. So we'll be talking mainly about chronic mitral regurgitation. Acute mitral regurgitation will not be addressed in this presentation. Then we'll walk through the guideline and discuss the guideline-directed management of chronic mitral regurgitation. And we have cases at the end to consolidate our presentation, and we solidify the information that we will talk about. So to start with, mitral regurgitation is the common form of valvular heart disease, and it's the second common cause of valvular heart disease in Europe, and it is associated with significant morbidity and mortality. The treatment decisions are completely dependent on accurate diagnosis of both mechanism and severity of the mitral regurgitation, which is sometimes might be challenging and often done inaccurately. And many times you see mitral regurgitation that's called otherwise mild or it's severe, and a lot of discussions about what is the severity, even among the most expert physicians. That's why understanding of the pathology and anatomy and the basics of this valve, it's very important and crucial. And of course, echocardiography plays a vital role in the management and diagnosis of these. And the most
Sorry, natig, we lost your sound.
case, you can hear me now.
Yes.
طيب انتوا الصوت راح وين في هاتوبار تقريبا عشان
بداية الانترودكشن.
طيب. Okay, so I was just telling about the introduction about the mitral regurgitation, that is common form of the valve disease, and it is the second common valve disease that's being faced in clinical cardiology practice in Europe. And it is associated indeed with a significant mortality and morbidity. Treatment decision completely dependent on accurate diagnosis of both the mechanism and the severity of mitral regurgitation, which sometimes can be quite challenging and demand a lot of discussions and different opinion, even among the eminent cardiologists around the world. Echocardiography play a vital role in the diagnosis and management of mitral regurgitation. The more time you spend in transthoracic echo, the more details, the more views, the more data you obtain from the transthoracic echo, the more easy and more fast could be your management without going to other alternative like transphageal echo or mitral regurgitation. So to start with the anatomy of the mitral valve, to understand the mitral regurgitation, the pathology, you need to have an understanding of the 3D structure of the mitral valve. So when you look at the echo in the 2D, you have to have in your mind, in your background, a 3D understanding of the mitral valve. And when we talk about the mitral valve, we talk about the mitral valve apparatus as a whole, is not only the mitral valve leaflet. So when we say assessing a mitral valve, we have to talk about the everything, starting from the two leaflet. As we know, the mitral valve has two anterior and posterior leaflet. The anterior leaflet is the wider leaflet that is on dome shape, and the posterior leaflet that crescent shape, and it is smaller than the anterior leaflet. Both leaflet has scallops, 3 scallops from lateral to medial, and we have indentation in between as well. So then we have the thin part of the leaflet that is redundant, and this is opposed against each other and acting as an orifice here and coaptation point. So any defect in this part that's lead to the one of the causes of the mitral regurgitation. And then these mitral leaflets are attached to mitral annulus, which is a fibrous band or fibrous tissue around the in between the left atrium and the left ventricle. And then after that, we extend the chordae. We have the multiple finger-like projection that goes down the left ventricle and then attached through the papillary muscle, the anterolateral and posterior medial papillary muscle to the left ventricular wall. So when we're talking about mitral valve, all of these things has to be addressed. We have to look on all details of every one of these. Every part has important and crucial role in the diagnosis and cause and management as well of the mitral regurgitation. So when we reflect this on the 2D or echocardiogram and 2D, either transthoracic or transesophageal, you're looking at the 2D picture, but you have to have in your mind at which view and which scallop is this. So when you see anterolateral A2, A2, B2, A1, B1, you have to understand the idea of the scallops, and you might see sometime anatomy or pathology in one view and it's not in the other view, that you have to have in your back of your mind that this is a 3D. You have to collect all the information and have a final background diagnosis in your mind. So regarding the classification of the mitral regurgitation, there are multiple classifications. We can classify it according to time frame, acute versus chronic mitral regurgitation. You can classify it also as a primary, where the lesions are organic from the mitral valve itself, like cases of mitral valve prolapse or any rheumatic heart disease, or secondary, which is secondary to underlying cardiac disease as well. Other classification is according to severity, mild or moderate, and we will go through that. The one of the classification, that Carpenter classification, this was actually made by a cardiac surgeon, and it mainly addressed the mitral regurgitation according to leaflet motion. So it had the type 1, type 2, and type 3. In type 1, we have a normal leaflet motion, such as cases in the annular dilatation or perforation. Type 2, we have excessive leaflet motion like prolapse or flail. And type 3, it's restricted leaflet motion, as in rheumatic heart disease or calcification. The other classification, as we said, that about primary or secondary, it's either primary mitral regurgitation, which the lesion is in the mitral valve itself, like cleft mitral valve, leaflet perforation, mitral valve prolapse, thickening of the mitral valve, calcification, or rheumatic heart disease. While secondary mitral regurgitation, it could be either due to dilated cardiomyopathy, ischemic cardiomyopathy, or the new entity, that atrial mitral regurgitation, as well as a part of the secondary mitral regurgitation. So this was like a brief introduction to the core of the topic, which is echocardiographic assessment of the mitral regurgitation. Treatment decisions are completely dependent on accurate diagnosis of both the mechanism and the severity of the mitral regurgitation. As we said earlier, this sometimes might be challenging and difficult. And the most commonly imaging modality that uses transthoracic echocardiography. And in some cases, with our data are not clear or data are inconsistent in transthoracic, we move forward to transesophageal echo, either to better visualize the mitral valve leaflet, or sometimes for better quantification of the mitral valve severity and mitral regurgitation severity as well. Unfortunately, the precision and reproducibility of these quantitative parameters in the echo and the measurements, it depends on meticulous technical points and numbers and measurement that make it difficult sometimes for reproducibility. And that's why we have to understand exactly the basic concept beyond it. So when we are looking at the echocardiographic and seeing a mitral regurgitation, you have to have at the back of your mind 3 questions that must be answered in every echo report addressing a mitral regurgitation. So the first question would be, what is the mechanism of the mitral regurgitation? Are we dealing with primary mitral regurgitation? Are we dealing with rheumatic heart disease? Are we dealing with prolapse? Are we dealing with something organic? And the second question, it's about the severity of mitral regurgitation. And this is the like most of the times the most challenging point. There are multiple parameters that we will go through in the presentation that you have to know, if not all of it, most of it. And you have to also be aware of the common pitfalls and the technical issues and the limitation of every one of these parameters. And then after that, you need to assess the consequence of this mitral regurgitation, looking at the LV, assessing the left ventricle, if it's dilated, assessing the ejection fraction and the left atrium as well. So in the echocardiographic assessment, we have 3 main categories that we assess in the echocardiograph. The first category is the qualitative measures that we use to assess the mitral MR, semi-quantitative or quantitative measure. So starting with the qualitative measure is assessing the valve morphology is by 2D color flow imaging and continuous wave Doppler. So when you look at the valve morphology from the 2D, you have many times you have a lot of information just by looking at the 2D. When you look at, for example, like a leaflet like this, when you see a posterior flail leaflet going this way, before even looking at the color, you can have an idea that this MR is severe. Do you have a big gap here? So this is very important even for assessing of the MR severity and even for the management later on as well. And when you see, for example, here as well, we have thickened myxomatous mitral valve with bileaflet prolapse. So you know here, this most likely Paulo disease, and this is most of the time from the first glance, you see this is unlikely to be, for example, for surgery because of severely redundant. And you know that MR most likely might be significant. And this view also, you can see classical changes of rheumatic mitral valve, the hook is thick and fixed. So here again, you expect to find some mitral stenosis as well, combined to mitral regurgitation. And here in this view also, by looking at this also, there is a large coaptation gap. So without color, you know, this is at least significant, if not severe mitral regurgitation. So always try to look at any details, any small things in the 2D before even moving forward, and try to obtain multiple views. 2D is very valuable sometimes, and sometimes give you information straight away from the first view. And the next qualitative measures is the color flow. And by looking at the color flow, we have to be also careful about the scale, about the technical part. And we look at the size and extent of the jet into the left atrium. And then we see, according to the extent of the color in the left atrium and how much occupying in the left atrium, that's how we grade the severity of the mitral regurgitation. And sometimes when you see also a large eccentric jet swelling in favor like this jet that goes all around the left atrium up to the other side. So knowing that even though it does not occupy most of the LA, this is most likely severe mitral regurgitation. So as per guideline, the regurgitant jet is for severe MR is more than 40% of the left atrium area. Definitely you take the left atrium area by tracing and then MR. Practical wise, we usually just look at it And you have to be also sure with the foreshortening of the left atrium. You know, when you take a 2D loop of the four chamber or two chamber assessing the left atrium, you have to be aware that uh, the left atrium should be open, the left atrium should be maximum. Make sure that the view is not foreshortened, that the focus is the left atrium, is not the LV. Look at this view, the left ventricle is foreshortened here, which we don't care about in this view as we're assessing the left atrium. There are limitations, of course, of this color flow assessment by the echo. The pitfall of this, the eccentric jet. So sometimes you see a jet like this. When you see a small color here, when we look at this at first glance, you might miss this and see mild MR or something like this, but this is actually a severe and might be very severe MR. When you see an occurred direction of the MR this way, very eccentric, always try to scan multiple views, try to angulate, try to look for the jet of the MR. So this is one of the limitation of the color flow imaging. The other limitation that it's the hemodynamic changes. It's really affected by the hemodynamic changes, including the hypotension, change in blood pressure, and sometimes even when you have large or huge dilated left atrium, then they will give you underestimation or give you false low percentage of the extension of the MR to the left atrium. So you need to be aware of all of these pitfalls and take all the measures in combination together. The third qualitative measure that we use for the assessment of mitral regurgitation is the continuous wave Doppler. The continuous wave Doppler have a lot of information as well. And usually we don't look at it and we just ignore it, and we are interested with the color Doppler just for the sake of time of the practice. But if sometimes you have small details in the continuous wave Doppler that sometimes give you the answer and the severity of MR as well. When you look at the color wave Doppler, we look at the density. As the envelope get more dense, as the severity of the mitral regurgitation getting more severe. As you can see, here is a mild mitral regurgitation, somehow moderate mitral regurgitation, and severe mitral regurgitation. But of course, this is not only enough to look at the density as well. You need to look at the shape of the mitral regurgitation. That gives you a lot of information as well. Looking at this shape, for example, you have the V shape or the cutoff sign here. This is looking at this only, you can say, I can put my money on this. This is severe MR. This is by itself, it's very sensitive for, very specific for severe mitral regurgitation. Again, what will give you another clue for this or other idea from this continuous wave Doppler is the timing of the mitral regurgitation. So if you saw this loop only in the 2D and color Doppler, you might see this is severe mitral regurgitation. Even if you take all other measures like vena contracta and Pisa, and you go and say this is severe mitral regurgitation, and this is common mistake we see in practice. The patient might come asymptomatic just only by this labeled as severe mitral regurgitation. But when you look at the color wave Doppler or continuous wave Doppler, you realize that this mitral regurgitation is not pansystolic. This is actually mid to late systolic mitral regurgitation. And when you go back and review all your 2D and color Doppler, you look at the mitral here, almost nothing, although this is systole. And you go again to the mid systole, you start to see some mitral regurgitation, but it's only shown in the late systole. While the other way around again here, you can see how here, early systole, look at the MR here. We have a very wide vena contracta. We have likely what you see at this, you see this is at least significant mitral regurgitation, but it disappear in the mid systole and appear again slightly less than before in the late systole. And here, just looking at this, you can say that this is biphasic mitral regurgitation, which is suggestive of ischemic mitral regurgitation. So from just looking at this, here you have an information that we have a mitral regurgitation that is biphasic, and this is most likely ischemic mitral regurgitation, that this is most likely secondary mitral regurgitation, not primary. We get all this information only from this envelope here. Okay, the second category of the assessment of echocardiographic measurement is the semi-quantitative measures, starting by the vena contracta. The mitral regurgitation jet, it's divided to a flow convergence zone here, and then vena contracta, and then the body of the jet or the jet expansion. The vena contracta is the narrowest beam. Here you can see in the jet. It's usually easy and quick. That's why people like it, but it has some limitations as well. It requires image optimization. So when you're assessing the vena contracta, your view should be focused, zoomed on the mitral regurgitation. So you don't pay attention here to the underlying structure, like say LV or LA. Your main focus is the jet itself. You try to open the maximum view that you can see the jet, zoom in that view as well. One of the good technicalities that we can use is the color compare, when you can have two images with color and without color for better measurement. And then make sure your scale is set from 50 to 60. And then the best view to assess the vena contracta is where the beam is perpendicular to the color, which is most of the time is the long parasternal view. So after knowing all these technicalities, you're sure that everything is doing in the proper way, and then you go on and assess and measure the vena contracta and take the numbers. The pitfall of the vena contracta, that is, as we say, it has a lot of technicalities. Sometimes same study, same images, two expert echocardiographer give you different results. So it needs really meticulous review and meticulous changes that you have to assess as well. And any small measurements or small mistakes in the measurements, it will lead to large errors in the severity of mitral regurgitation. And the other pitfalls of that also, sometimes we have multiple jets, so it would be difficult to assess the severity. Although some experts said you can sum the vena contracta, but this is still not very accurate, and it's controversial. And the other pitfalls that sometimes you have a dynamic or a lot of time we see, especially in the secondary MR mitral regurgitation, we cannot say where is the vena contracta. You see two echocardiographer expert looking at the echo, trying to figure out where is the vena contracta, because you don't see a clear orifice. You don't see a clear neck. So this is also one of the pitfalls of the vena contracta measurement. And then the third semi-quantitative measurement is the pulse wave Doppler of the pulmonary vein flow, where we see here from the four-chamber view, you put out your pulse wave at the pulmonary vein, either the right or the left. And normally we have systolic wave and then diastolic wave, and the systolic is larger than the diastolic wave. So this will give you again information. If we have systolic blunting, it does not necessitate that it is moderate MR, but it's supportive measurement. But if you have systolic reversal, this is likely severe mitral regurgitation. Okay. Again, the pitfall for this pulse wave Doppler, that it is influenced by the hemodynamics again. If you have a large left atrium, if you have any impaired diastolic dysfunction or impaired LV relaxation, especially advanced, it will all affect the pulmonary vein wave. And again, if you have an atrial fibrillation, will be out of the equation. So if you have atrial fibrillation, don't use pulmonary vein flow. And the third part is the quantitative part, which is the PISA method and the volumetric methods. I would say this is, most of the time, this gives you the answer. If you are in conflict about the severity of mitral regurgitation, if you did the quantitative method, it will confirm for you or exclude for you the severity of severe mitral regurgitation, given that you have done it in the right way, in the right technique, and the accurate measurement. If you spend some time while you're even scanning for that echo, making sure that you took all the number needed for this, this might prevent you from proceeding for transesophageal echo in many cases. So the quantitative measures that we look at is the effective orifice area, regurgitated volume, and regurgitated fraction. Before we move for these measures, we would like to explain one of the basic concepts in echocardiography, which is continuity equation. This is one of the most important concepts in the echocardiography. I think every cardiologist must understand this thoroughly in detail. Guidelines can be changed, guideline can be updated, but the basic concept will remain there as long as you practice cardiology and echocardiography. So a continuity equation is one of these basic concepts. Simply, I try to make it as simple as possible. Continuity equation, it's what comes in equal to what comes out. يعني الحجم الداخل كما هو الحجم الخارج زي ما قالوا في الفيزيكس. So in any closed chamber, the amount of volume that goes in here is equal to amount of volume that goes out here in the same time. If we apply this in the heart, so we have the same time, which is systole. So this is the same time we are talking about this systole. So the amount of blood that goes in here should equal the same amount of blood that goes out to the aorta. This is the basic principle of the continuity equation. Okay, given that this is a normal healthy myocardium. So V1 equal to V2. Then the question is how to know, how to calculate the amount of volume that comes here, or the blood that comes here and goes out. So again, the volume, it's equal area multiplied by the VTI. أو كما زي ما في الرياضيات اللي هو الحجم كان بيقول لك المساحة في الارتفاع، مش حجم المخروط. نفترض إنه مخروط، لأنه إحنا قارين رياضيات بالعربي، فنفترض إنه المخروط بيقول لك حجم الدائرة بالارتفاع، في الارتفاع. Take this principle as long as you're talking about continuity equation in anything, in septal defects, in valvular lesion, in anything. بس put this concept in your brain. المخروط اللي هو الدائرة في الارتفاع. Okay. So now we're talking about the volume that comes in here in the mitral valve. الدائرة هنا it is the mitral annulus, that's a circle, assumingly. So that's now when you know when we say دائرة we assume, and this is one of the limitation. So عندنا هنا the mitral annulus is the area, and we have the blood inflow through the mitral valve اللي هو زي ما قلنا هنا الارتفاع اللي هو reflected by the VTI of the mitral valve. Okay, if you put the pulse wave, you have the E and A. تمام? And the same applied in the aortic valve. The cross section of the aortic valve here, the area is applied by the VTI of the aortic valve. That give you what's called the stroke volume. So stroke volume here equal to stroke volume here. So this is again here applied in the echo. If you want to apply it, you take the mitral annulus, measure the mitral annulus, and measure the LVOT. Okay, and then you take the VTI, which is here of the mitral inflow, and the VTI of the aortic inflow. Okay, and then what is the area? We are talking about area, but here we are measuring a 2D line. That's why you need to understand the 3D concept. So we are measuring a 2D line. That's a straight line, but we are talking about an area. So we are talking about an area. We'll have the equation of, it's not written, I think here, yes, 3.4 على diameter by 2 over 2 اللي هي كانت في الرياضيات زمان مساحة الدائرة طا نق تربيع، مش كده؟ فدي هي نفسها طا نق تربيع. تمام؟ فاحنا we're talking about this circle here in the mitral annulus multiply by pi and then multiply by the VTI. طيب this is for the aortic and mitral. طيب the first the other thing برضه في من ال quantitative measures it's the BISA. BISA if you think about it is almost the same concept as we are talking about اللي قبل شوية اللي هي what comes continuity equation what comes in goes out. احنا we were talking هناك في ال previous about mitral and aortic. هنا we will talk about this area as an A1 V1 and this area which is the regurgitated office as A2 and V2. تمام؟ the same exact concept. So الفوليوم هنا اللي هو A في V1 equal A في V2. to make it يعني more easy اللي هو A الاريا هي اللي هي بنحسبها الفوليوم هنحسبها باي ايكويجن 2 باي ار سكوير في الفي الفيلوسيتي اللي هي we can get it here من minus 30. تمام. طبعا before that the technical part of the PISA just to review it the same as the vena contractor. You have to zoom in, you have to make your scale clear, you have to get the whole jet, you have to look at the neck, the flow convergence zone and the body of the jet, and then you decrease the scale and decrease the baseline on the direction of the jet. So if you are in the transthoracic, you go down. In transesophageal, it will be the other way around. So we decrease the baseline. It is minus 30. Our target is from minus 30 to minus 40 in the BISA. And then you take the measurement lower radius. A radius should be measured from here. You make a line around the vena contracta and then up to this area. Don't take the blue color with it. So we take it from here up to here. Okay, and then we apply الكونسبت اللي قلنا عليه في الكونتينيوتي ايكويشن اللي هو A1 V1 equal A2 V2. هنا A1 we get 2 by R square في ال V. From where هنا ليه هنا في 2? Why did we have 2 here? Why here هنا ما في 2. It was only by D على 2. What is the difference من الرياضيات يعني أو physics؟ Any idea؟ في واحد عنده أي idea why did we get 2? Why did we add 2 here? طيب we'll say لأنه echo is about assumption and this is one of the limitation. احنا we assume that this pizza is a globe, is a spherical كروية يعني حاجة دائرية. ما it's not like here where we're talking about circle. هنا we're talking about circle. لكن هنا we are talking about sphere. يعني ما حاجة مسطحة about كورة يعني زي الكورة. فهي من الفيزيكس أو الماث الفوليوم الحجم equal في المعادلة حقت الرياضيات 2 by r square and that's why we have 2 here. لكن the concept is the same. It's volume and في velocity. تمام. And then accordingly when you calculate this calculation you add the numbers هنا R2 and هنا velocity and then when you come here اللي هي area 2 you have the V max من ال CW color continuous wave of the mitral regurgitation. You have the maximum velocity 6.4. So we have an A1 area, we have a V1 area equal to V2. تبقى لنا بس الاريا اللي هي A2 which is reflected by effective orifice area. This gives you the equation of the effective orifice area that we know from the book. So if you understand the basic concept, from where did we conclude our equation, from where did we get all this data, you will never forget that, and you will make it easily in the multiple times in your practice. Any question here before we move forward?
No.
Right. What are the pitfalls for this measurement, quantitative measurement? Pitfalls is most of it is technical part. Like measuring the annulus. Many times when we have MR, we have a calcified mitral valve, we have a calcified mitral annulus or MAC, and this will have a limitation and have an impact on the measurement of the mitral annulus diameter. And other thing also is the technical where we put the pulse wave Doppler. And in diastolic dysfunction, we put the cursor for the pulse wave toward the ventricle. But when we assess the volumetric measurement here, you should not use the same pulse wave Doppler which is assessed in the diastolic dysfunction. You need to move the cursor a little bit at the level of the mitral annulus. So this is one of the technical part that lead to the mistake. The other pitfalls is if we have concomitant aortic regurgitation, it will not be accurate as well. The criteria for severe mitral regurgitation as per the European Society of Cardiology and American is almost the same. We gave you the criteria in the qualitative, semi-quantitative, and quantitative. If you have flail leaflet, ruptured papillary muscle, severe retraction or perforation, again from the 2D, you know you have most likely having severe mitral regurgitation. From the color Doppler, if you have a jet central area more than 50% of the left atrium, or eccentric wall impinging of variable size. This is again giving you a clue about severe mitral regurgitation. Or if you have flow conversion through all the systole, this is again a clue about towards severe mitral regurgitation. Again, the shape of the continuous wave, as we see earlier, that very dense shape, triangular, holosystolic, indicating severe mitral regurgitation as well. Regarding the semi-quantitative measures, are the vena contracta more equal than or more than 7 millimeter. If you have a systolic flow reversal in the pulmonary vein, then you have a severe mitral regurgitation. In the mitral inflow, if you have a dominant E wave more than 1.2, although this is not specific, but it might have a good negative predictive value. And then the quantitative measures are the effective orifice areas more than 40 millimeters square, the regurgitated volume more than 60 ml, and the regurgitant fraction more than 50%. And then if you have, as a consequence of the mitral regurgitation, if you have a dilated left ventricle, so this is not by itself, it's not enough to say like severe mitral regurgitation, but this gives you a clue in addition to your other information that you might have a severe mitral regurgitation as well. We will walk through the guidelines for the management of the mitral regurgitation and intervention of indication of intervention in the European Society of Cardiology. However, it's almost similar to the American College of Cardiology as well. So echocardiography is the first choice always in the grading mitral regurgitation. The asymptomatic patient with moderate mitral regurgitation and preserved LV size and function can be followed on yearly basis, and echo should be performed from 1 to 2 years. So when various echocardiographic parameters used to grade mitral regurgitation are inconsistent, consider other modality like mitral regurgitation, like cardiac MRI or transesophageal echo. And then one point of the European Society of Cardiology, they mention about exercise echocardiograph. If you have a patient having moderate mitral regurgitation that is inconsistent with the symptoms, let's say a patient is symptomatic or presented with moderate mitral regurgitation, think about exercise echocardiography and assess the pulmonary pressure and the mitral regurgitation severity as well. So as a recommendation for the mitral valve repair is the recommended surgical technique when the results are expected to be durable. So repair is always superior to surgery, to replacement. Surgery is recommended in symptomatic patients who are operable and not high risk. This is class 1 evidence. Surgery is recommended in asymptomatic patient with severe MR who are asymptomatic. They are candidate for surgery as a class 1 level of evidence when they have either dilated LV more than 40 millimeter or reduced ejection fraction less than 60%. So again here, surgery should be considered in asymptomatic patient with preserved LV function and atrial fibrillation secondary to MR or pulmonary hypertension with a less evidence, a class of evidence 2A. So we have indication for intervention. To summarize it in the severe mitral regurgitation is symptoms, number 1. Then consequence of the mitral regurgitation itself, either dilated LV or reduced ejection fraction. Both of them are class 1 evidence. And then if you have an asymptomatic patient, normal LV size, normal LV function, you have an either atrial fibrillation or pulmonary pressure more than 50. This by itself is an indication to send the patient for surgery. The next point is surgical mitral valve repair should be considered in a low-risk asymptomatic patient with ejection fraction more than 60 and systolic dimension less than 40 and significant left atrial dilatation with an index more than 60 ml per meter square or diameter more than 55 millimeter when performed in a heart valve center and durable repair is likely. So this is giving that it should be an expert center with a high likelihood of success. Again, here to summarize it, patient with severe chronic primary mitral regurgitation. Focus here that he said severe, chronic, and primary mitral regurgitation. So we're not talking about secondary mitral regurgitation. So if we have patient have symptoms, so go straight away for surgery, giving that the patient is not high risk of futility, okay, or meaning that the expected life expectancy. If the patient does not have symptoms, go and assess your left ventricle. Is your left ventricle normal? Assess the size, assess the ejection fraction. So if you're having reduced ejection fraction, you have a dilated LV, this is a class 1 indication to go for surgery. Again, if we assess the LV and the left ventricle is normal size, normal function, look at the patient, is asymptomatic, then does the patient have atrial fibrillation? Does the patient have systolic pulmonary pressure of more than 50? If you have an atrial fibrillation and systolic pressure more than 50, pulmonary pressure more than 50, then yes, again, this is an indication of surgery with a lower level of evidence or lower level of recommendation of 2A. Then let's say patient is asymptomatic, normal LV size, normal LV function, no atrial fibrillation, no pulmonary hypertension, came for routine follow-up. What would be the next step? Should we go for surgery or no? This will depend on the center that you're working on. If you have an expert center, if the likelihood of repair, not replacement, if the likelihood of repair is more than 90% and patient is low risk surgical risk, especially if you have left atrial dilatation, then again, this is a class 2A indication for surgery. Otherwise, if all of these are negative, you go for follow-up on that 6 month to 12-month period. This was in the primary mitral regurgitation. Now we will talk about secondary mitral regurgitation. See the valve surgery / intervention. When we talk about secondary, you see intervention comes in here because surgery is not preferable in the secondary mitral valve. Intervention is almost taking over from the surgery. So If we have valve surgery and intervention is recommended only in patients with severe secondary mitral regurgitation who remains symptomatic despite guideline-directed medical therapy and has to be decided by a structured collaborative heart team. So in secondary MR, you have to give the patient all the maximum tolerated guideline-directed medical therapy before thinking of intervening the mitral valve with a level of evidence 1. And then they divided the patient with secondary mitral regurgitation into patients with concomitant coronary artery disease or other cardiac disease or without coronary artery disease. So in patients with coronary artery disease, ischemic heart disease, who come to you with severe mitral regurgitation, valve surgery is recommended in patients undergoing CABG or other cardiac surgery as a class of evidence 1B. Okay. But in patient who is symptomatic patient who are judged not to be appropriate for surgery by the heart team on the basis of their individual characteristics, then you go for PCI, percutaneous intervention, for the coronary artery disease if the patient is indicated, and if the patient is having any other disease like aortic stenosis, or then you intervene, you manage the underlying cause, you manage the coronary, manage the aortic valve, and then after that, assess the mitral valve again. If you're still having severe MR, go for intervention. And again, they put here intervention, not surgery, by mitral valve clip. So again, just to review this, because this is one of the common scenario, if you have secondary mitral regurgitation, treat the underlying cause first. First, second, third, and the last thing, then look at address the MR. If the patient is having coronary artery disease, address his coronary. If the patient is having aortic stenosis, address his aortic stenosis by TAVI. And then after that, reassess the mitral valve. If still persistent severe mitral regurgitation, proceed with mitral valve clip. So what about the patient who are not having coronary artery disease? Transcutaneous edge-to-edge repair should be considered in selected symptomatic patient, not eligible for surgery and fulfilling criteria suggesting increased chance of response to treatment. And this is the area of debate usually in the heart team, whether the patient to go for mitral valve clip or no. But the main role here that always you have to be on the maximum guideline-directed medical therapy before talking about addressing any secondary mitral regurgitation. So this is again to summarize the secondary mitral regurgitation management. So look at the patient. Is he symptomatic despite guideline-directed medical therapy? Then refer to heart team. Again, optimize guideline-directed medical therapy. So they keep addressing about medical therapy. Always optimize medical therapy. Look at the patient. If he is indicated for CRTD as per guideline, put CRTD before you put any intervention, before you proceed with any clip. Then after patient is being under all of this and still he is symptomatic, assess the patient comorbidities and life expectancy. If it's more than 1 year, then you go further and assess his coronary, assess his other cardiac disease, assess his aortic valve. If he's having any aortic stenosis, go coronary artery disease, go with PCI, and then go back again and assess his mitral regurgitation after that. If it's still persisting, still severe, then you go and see if he is appropriate candidate for surgery, yes or no. If he's surgery or intervention, then if he is candidate for that, you go for surgery. If he is not candidate for surgery, and then you go and assess if he is fulfilling the criteria for mitral valve clip by different means of measurement and different technicalities, usually discussed in the heart team meeting. So if he is candidate for that, you can proceed with mitral valve clip. But the main point here in secondary mitral regurgitation that guideline medical therapy, addresses coronaries, addresses other things, and then assess the mitral regurgitation again. So I think here we come to the end of the theory part. I just have some cases just to consolidate what we have discussed, and just to also understand more, especially the echo part of the assessing the severity of mitral regurgitation. Yes, I would like maybe 2 or 3 candidates to go through the cases with me if possible.
Okay, we'll take this.
تمام. اوكي. اسم كريم.
طلال.
طلال. اوكي اتفضل طلال.
68 years old male with history of hypertension and atrial fibrillation, presented with progressive shortness of breath and mild fatigue over the last 6 months. Notice that his exercise tolerance significantly declined. His blood pressure 130 over 80, altitude 82, irregular systolic murmur is here the apex, lung exams, snoralis, autopulmonary edema, echo shows mitral annulus diameter 3.8, mitral VTI it is 125, LVOT 2.2, LVOT VTI is 18.
تمام.
What is the next step in management? Observe and repeat the echo in 1 year. It is not linked because it is symptomatic. Medical therapy with beta blocker and diuretics. Refer to the mitral valve surgery. Repeat the process of echo in the 6 months.
Let's go back question. So, we have a mitral regurgitation, right? By examination, most likely.
Yes, yes.
Well, echo, we give us parameters, and we want to know, is it moderate? Is it severe mitral regurgitation?
Yeah.
And you do the calculations.
Just 1 minute. Very bad. Just 1 minute.
ايوه.
3.8 هتكون
يعني الايديا ما اظن، يعني حتى لو ما حسبت الارقام، بس الايديا انه ملتبلاي الايكويشنز and then we will walk through it. يعني احنا
طيب هتكون الميترال انجلس في الميترال في تي اي
تمام.
على ال بي او تي دايمتر.
احنا لو حسبنا كده الميترال انيولس بير سي يعني 3.8 تايمز البي تي اي 125، يعني 3 في 8 ملتبلاي باي 125.
ايوه.
احنا هنا we are talking about diameter، صح؟
يس.
2D. لكن احنا we are really assessing a 3D a circle، صح؟ فقلنا باي ار سكوير، صح؟ اللي هي 3.4. ايوه. فانت first you make this as a cross section of the mitral valve، صح؟ تحسب الميترال annulus area، صح؟
طيب.
ف we calculate this 3.14 3.14 في R square, and then you multiply it by the mitral VTI. بيدينا شنو هنا؟ stroke volume، صح؟ mitral stroke volume. stroke volume through the mitral. ممتاز ممتاز excellent. طيب تاني بعدين we apply the same thing on the aortic VT. ايوه again you multiply 2.2 في 3.14 and by R square عشان يدينا الاورتيك ستروك فوليوم، رايت؟ او ال في تي ستروك فوليوم. تمام. So هنا احنا we have the mitral stroke volume, we have the aortic stroke volume. تمام. In normal situation they should be equal to each other، صح؟ اللي هو
Yes.
فاحنا we check the difference and this will be the
regurgitant volume.
regurgitant volume. تمام excellent. تمام ممتاز. بعد ذاك نحسبها الفراكشن. احنا we'll go through it هنا واحدة one by one. طيب هنا step 1 هنا هو بدأ بالال بي او تي stroke volume. فهي تشيك ستروك فوليوم في ال بي او تي زي ما قلنا ال بي او تي diameter في باي على 2 تربيع في multiply by ال بي او تي في تي اي. تمام. حسب الحسابات هنا all the calculation ودانا approximately 69 ml. طيب the same step in the mitral valve زي ما عملتها exactly the same by d over 2 square mitral valve VTI. We calculated the stroke volume in the mitral هنا 142.
Yes.
So we have the stroke volume across the mitral valve and we have the stroke volume across the aortic valve أو the LVOT.
which is
أيوة.
the severe يعني called the severe.
Yes. وهنا هي minus stroke volume of the mitral minus the LVOT equal to 73 ml. So the regurgitant volume is 73 ml, which is severe.
Severe.
تمام.
Yes.
والفراكشن regurgitant fraction احنا الفراكشن we want to know ال 73 ml دي how many percent من الستروك فوليوم اللي دخل الميترال كله يعني نسبة. فاحنا we take a 73 divided by stroke volume of the mitral valve multiply by 100 يعني 51% of the blood that goes in the mitral goes back to the regurgitation. So the regurgitant fraction is 51.4%, which is again confirming our finding of severe mitral regurgitation. تمام. So هنا طلال will answer will be
refer to the mitral valve surgery.
refer to the mitral valve surgery because of symptoms. تمام. Excellent. طلال يديك العافية. And who will take this, the next case? Yeah, almost the same concept. Any candidate? Nasin, Umayma, Iman, Mahdi. Anyone will take it? طيب خلاص I will walk through it. A 65-year-old male with a history of hypertension and chronic atrial fibrillation presents for routine follow-up. He denies any shortness of breath, fatigue, or palpitation. يعني patient is asymptomatic. So he has been asymptomatic with a good blood pressure control and his anticoagulation with warfarin. His blood pressure is okay, heart rate is irregular, around 80 beats per minute. An examination showed holosystolic murmurs heard in the apex radiating to axilla, meaning that he's having most likely mitral regurgitation. And then echocardiographic finding, he give you these parameters. Mitral annulus diameter is 3.8, LVOT diameter is 2.2, VTI MR jet is 160 centimeter, VTI of LVOT 25, liaising velocity of V, maximum liaising velocity of 45 centimeter per second, البيزا radius or convergent radius 0.9, left ventricle is normal in size and function, and give you the peak velocity of MR 5.5. So the question is based on the data above. What is the next best step in the management for this patient? فاحنا قلنا patient is asymptomatic. Then calculating this measurement again بنفس نفس equation. بس هنا this time we are gonna use البيزا method. تمام لأنه ما ادانا الميترال inflow VTI.
Yes.
Now we will use البيزا method in this question scenario. البيزا method اللي هي A1 V1 equal to A2 V2. تمام. A1 will take it is where is it, a radius here 0.9 and then we multiply 3.14 as per the equation في V1 45 and then V2 عندنا هنا طبعا you have to pay attention, this is centimeter and this is meter, so you change it to centimeter and then you put it in the equation. We'll give you the V2, which is effective orifice area. We'll go here to in the equation using the Biza equation or Biza method, as we said. The effective orifice area, you put A1 0.9 for V1 45 from the scale, and then he changed the Vmax from meter to centimeter, then 550, and then he gave us a final conclusion of 0.42, which is consistent with severe mitral regurgitation. Again, to confirm this finding, he calculated the regurgitant volume by multiplying this number on the VTI of the mitral regurgitation, and he gave us a volume of 67. So we have severe mitral regurgitation by the BISA method, by ARO, and by the regurgitant volume. So what will be the next asymptomatic patient? Severe mitral regurgitation. Refer to mitral surgery. Start medical therapy with beta blocker. Perform TEE for further assessment for follow-up with repeat echo in 6 months.
That's also referred for the surgery.
Excellent. Halal?
Yes.
Tamam. Excellent. Why refer for surgery?
Because severe and also the patient in AF. Yes.
Excellent. Because you have atrial fibrillation
Mm.
and severe mitral regurgitation. Okay.
But this is the calculation is coming automatically in the machine. Yes.
لا, this calculation ARO.
Yes.
ايوه انت if you label, if you have a reporting system that allows you to label, يعني انت من البدايه اخذت الميجرمنت ويو ليبل البيزا as a بيزا وعملت الليبلز, it will give you automatically. لكن this is not most of the time. يعني لازم you have to label it by the machine. تختار انت this is pizza radius, then you do it وتعملها label, and then they give you. لكن you have to be very meticulous, لانه if you took 2 measurement 3 measurement he will take, الماشين will take the average, او ال reporting system will take the average. فانت you have to manually just go adjust the يعني شوف النمبر اللي انت عايزه تاخده في الايكويشن الميجرمنت اللي you think it's correct. You look at technicality and this is the number you want to take, make it, choose it, and then the reporting system will take it automatically and give you the answer. تمام. Especially for the people who's going to the European Board of Echocardiography, they are very meticulous with these numbers and measurement in the report. طيب, they refer for mitral valve surgery, as you said, because of atrial fibrillation. As you said, it's atrial fibrillation, patient asymptomatic, normal LB, but he has atrial fibrillation, and this is class of evidence is 2A. طيب, طلال, ناخد معاك الكيس الأخيرة. This is the last case.
62 years old, male with history of ischemic heart disease, presented to the follow-up visit. He has history of myocardial infarction. He has gone percutaneous coronary intervention for coronary artery disease in the past. His current medication include bisoprolol, sacropril, valsartan, spironolactone, dapagliflozin, and aspirin. The patient reports no new symptoms, but he has history of exertional dyspnea, class 2 to 3, and occasional fatigue. Physical examination blood pressure is maintained 130/80, heart rate 62, and regular cardiac examination, grade 3 holosystemic murmur at the base of the apex, radiate to the axilla. Lung examination is clear to auscultation with no crackle.
تمام. يعني as a summary, the patient with ischemic heart disease عامل PCI on medical therapy for heart failure, and he is symptomatic.
Yes.
طيب, this is his data.
Okay.
ECG, simple.
ECG is 12 lead ECG, shows sinus risk with left bundle branch block with heart rate about 50 something or 60 something.
Okay, تمام. And
Uh,
then,
echo four chamber view shows the MR is take more than 50% of the left atrium. It is central.
تمام.
And BW in the pulmonary vein shows it is severe. It is reversal of systolic.
Yes.
Goes severe MR.
تمام, ودي confirming انه في عندنا severe mitral regurgitation. Okay.
Yes. Based
Okay.
on this above, the next step in the management refer the patient for the heart failure clinic device therapy. This is secondary MR. It's not primary.
Okay.
This is always good for medical treatment and then we assess. So refer to the clinic heart failure and device therapy and accept this. Refer to the percutaneous. Refer to the
I will.
mitral initiating.
Mhm.
So refer to the clinic heart with the advice therapy, the device therapy. Should
Or
be met first
so
and then assess.
what will be the next step في المانجمنت لو انت حولته for
Uh, for heart failure clinic and device therapy. This is the therapy.
device for CRTD specifically لانه عنده has left frontal branch block صح؟
Yes, yes.
Exactly. Excellent. شكرا دكتور طلال. So again the same بس عشان to review approach management of secondary mitral regurgitation symptoms despite guideline directed medical therapy. And he mentioned في question he's in maximum tolerated guideline medical therapy. So يعني medical therapy is already taking over to the maximum, and then CRTD when indicated. And this patient have a wide QRS, approximately almost 140, 150 تقريبا. So the question here will be CRTD before proceeding to the next step. Thank you very much. ده كان آخر case. You have any question or any point for discussion or review? Go ahead, please.
دكتور محمد